Welcome back. I hope you're able to take full advantage of our speed networking function. Now let's move on to our next topic, focusing on addressing health inequalities using digital tools in partnership with Tell Me. Health inequalities are a pressing challenge worldwide, with underserved communities often facing barriers when it comes to accessing quality healthcare. The focus of this panel is to bridge the gap and highlight the transformative role of digital tools in tackling these disparities and promoting equitable healthcare outcomes. The NHS has made a long-term commitment to reducing health inequalities, and through digital services, we see an improved take-up of tools to help with long-term conditions with better outcomes. Digital tools usually offer cost-effective and scalable support, so can be rolled out to large areas very rapidly. There are many reasons people don't access treatment, for example, wait times, practical barriers, and perceived stigma of getting help, all of which can be addressed with technology alternatives to traditional routes. So, with me to discuss this subject, I'm delighted to welcome Susie Godson, co-founder and co-CEO of Tell Me, Faris Al Ramadani, Clinical Director of Warwickshire East Primary Care Network, and Helen Hoyland, Innovation Lead for Yorkshire ASHN. Don't forget to join in with the conversation by using our Q&A function at the bottom of your screens. Lots of people put questions in last time, so let's keep that conversation flowing. So welcome to all our panelists. Faris, you're looking all official there with your headphones on, so I'm going to kick off with you, if that's okay. Just in your opinion, describe for us what you see as health inequalities.
Sure, thanks, Helen. So health inequalities essentially are identifying factors that lead to differentials in patient outcomes and health outcomes, either in accessing health or actually in being able to deliver health. So health inequalities are really important to us as clinicians because in our job we want to try and improve the health of our entire population. So by understanding health inequalities, we can better understand people who are being left behind, and that helps us then think about what sort of solutions we need to be offering and delivering so we can help those people who like we said, are being left behind. So understanding health inequalities is a really important way for us to better understand how we can raise the health and well-being of our entire population. And factors that might create inequalities might be things like socioeconomic status, ethnicity, and language as a result of that. It can be geography, level of education, gender. So there's very many things that can create an inequality. And so our job is trying to find where we plug those gaps in.
And Faris, how do you think digital tools, this is a big question, help overcome health inequality and promote better outcomes for all? Perhaps generally to start with, and we can dig in deeper as we bring Helen and Susie into the conversation about more specific ways.
Yeah, when I've read about this subject previously, it always comes across as a bit of a double-edged sword. And some people say, well, aren't you creating an inequality because not everyone has access to digital? We don't have complete digital literacy across the entire population. Not everybody has access to the internet and a device that will be able to access some of this technology. So it is true to say that there is an inequality in itself, but I think we probably need to think more about the fact that digital solutions can serve as an adjunct or an additional option to what we already have available. So there are some people who are left behind by traditional forms of access to healthcare, and it's perhaps those population groups that we can access better with digital. So digital is not the one solution for everything. If it was, then that would create an inequality, but actually it helps remove inequalities by giving more options to more people without necessarily removing the more traditional methods of both treatment and access to healthcare. I think at the moment, from my perspective as a GP and what I'm seeing at the moment, digital is not new. It's always been there. So we have digitalized computer systems within primary care, which means we've got access to wider amounts of information. Digital is part of the fabric of our society now through social media, so and the use of mobile phones. So actually digital is no longer something separate. It's part of our day-to-day life. What we see in terms of real benefits right now is patients can use, say, actually digital can impact on many things, but access to healthcare has been improved with things like the NHS app and other ways of actually booking appointments, so you can actually access healthcare more easily. We can use digital to help inform patients. So we use social media channels. We use products that allow text messages to patients to deliver them information more quickly. Access to their patient records is a digital solution, but it's empowering us take more control for their own health. So we've got access, we're allowing them to better be informed. We're using digital to help diagnose. So, we've got digital solutions within the clinics now that will allow us to diagnose patients far more quickly, which is great. People have digital health tech on their watch. The Apple Watches and the other smart watches might diagnose atrial fibrillation. So we've got a diagnostic component, and we've got a treatment component. And whether that's, we've had some experience of using Silver Cloud, and we've got Susie from Tell Me looking at digital solutions to actually deliver the service. So really the full spectrum of our healthcare can be impacted upon digital, and it's about utilizing or finding out which areas and which patients are being left behind so they can better access care using these digital solutions.
I'd like to say a big warm welcome to Susie. You've not been with us on one of our events before. So tell our audience a bit about Tell Me and how Tell Me is helping bridge that gap that I mentioned in the introduction, to try and bridge the gap with health inequalities.
So Tell Me is both a native app and a web platform for young people. We're working in the mental health space, but Tell Me is a very broad-based community solution. It's a scalable solution because we're using a peer support model, which enables young people to help themselves by helping each other. It's pre-moderated, so every post and reply is checked and risk assessed by a human. We have a preemptive counsellor intervention model, so if a child makes a high-risk post, it immediately gets picked up by a counsellor, and that means the young person doesn't have to ask for extra help. That help comes straight to them. And we have an integrated directory which has well over 600 resources, and that is filtered by topic and by postcode. So when we're commissioned in an area, we go out and we engage with all the local support services, community-based groups, charities, support services recommended by the NHS, and we build them into the directory so young people have access to absolutely everything in their area. And they can also filter the feed by topic. So we have over 200 topics that they can choose from. And when they click on, for example, autism, or they click on anxiety, it filters their feed and they join conversations that are relevant to them. And they're talking with peers within an age-banded community. So everyone is within 2 years of their age. And it just makes it very easy for them to get to communities that are relevant to them, and it's completely anonymous. And that's really important, because in order to engage young people who are at risk of health inequalities, you have to get rid of the possibility of stigma or judgment or the idea that they might be marginalized. By making it anonymous and by having pre-moderation, it means they know they're not going to be judged. It makes it really easy for them to talk about difficult things, stuff they may not have told anybody about, that they may have been bottling up for ages. And it is the first step towards building the confidence to then go and see if community solutions or anything that's in the directory can offer them further support.
Just briefly, Susie, because I'm very aware that I haven't said hello to Helen yet, and sitting there patiently in the bottom left of my screen. But I noticed you're the co-founder of Tell Me. I mean, that work, particularly in mental health and autism, sounds extraordinary, and it really is something that's very much needed, where people can feel safe and anonymous and share and not feel alone. But what prompted you? There must be, I'm guessing there's a story as to why you came up with the idea to do this.
Yeah. Well, I'm a psychologist, but my background is in design. My co-founder, Shoshtan, is an engineer, but when we met, she had just finished building a free school in the most deprived parts of East London. And I also work as a journalist at the Times and as an agony aunt. And so I was constantly getting emails and letters from young people. And I just knew that if they could speak to each other, if they could see that they were all going through the same things, that they'd be able to support each other. And that advice from me wasn't going to change it, but that peer acceptance, that capacity to be able to relate, and think, oh my gosh, I'm not weird, I'm normal, there's other people like me. I just knew that would have a profound impact on young people, and that really has proved to be the case.
Gosh, that's amazing. Helen, lovely to see you. You've been with us before. I know that you'll probably see a lot of health inequalities from where you sit across the NHS, but your team supports SMEs and innovators and NHS organisations with rapid testing, adoption and scale of innovations. Can you share perhaps some examples of the digital innovations that you're using already or that you've got coming up in the pipeline that can really make a difference in the bridging the gap?
Hi, yes, nice to see everybody. So I'm from the Academic Health Science Network in Yorkshire and Humber. So I'm one of 15 AHSNs across the country, and we see several hundred different types of innovation through our doors really every year. Everything across a really broad portfolio, but there are lots and lots of digital products there. They could be diagnostics, they could be patient-facing apps, they could be population health level, AI. There's many things. And what we try to do really is to try and work with the innovators to help them understand potentially, is their innovation going to help narrow the inequalities gap? Is there any risk that it may inadvertently widen the gap? And to get them to be thinking about the impact of health inequalities as they go on their journey of adoption. So the AHSNs, we work with the innovators themselves, so SMEs, innovators, clinical entrepreneurs, and the NHS, and we try and bridge that gap to try and get things piloted, tested, and adopted. So we look across a broad portfolio really. In particular, at the moment, we've been working with the Accelerated Access Collaborative and NHS England on what's called the Core 20+5 agenda. So in particular, we're looking at innovations in the space around, for example, cardiovascular disease, respiratory, cancer, maternal, and mental health. They're some of our bigger themes. But in particular, we're really interested in digital as an enabler. So as an example, one of the innovations we're working with at the moment in West Yorkshire is looking at the translation of medicines labels. So if you don't speak English as a first language, you go and get your prescription from the doctor or from the hospital, and you're not quite sure how to take it safely, what the dosage is. So there's a fantastic innovation out there at the moment which will translate those. It sounds incredibly simple, not been done before, but hopefully can have a really impactful benefit on patient safety and outcomes. So that's one example.
Gosh, that sounds amazing work that you're involved in. I'm just casting my eye, Faris, over to contributions from people in our audience. And the word postcode lottery has come up a couple of times on a couple of comments. Stephen says, why is there still a postcode lottery with regards to technology such as continuous glucose monitoring with Libra sensors? And also, Carol says there's a postcode lottery regarding electronic patient records. I have access to my GP records, such as they are, but no access to hospital records. Do you find that there is still a bit of a postcode lottery going on, Faris? And can this digital world perhaps help stop that?
Yes, there is. There is a bit of a lottery at the moment, and part of that perhaps is down to funding. So, what would be great is national level funding for digital solutions, really, because at the moment you may have solutions, and some ICB areas may take up the offer of those solutions, and some may not. So, yes, there is that problem. The more that we can get national level funding for technology and innovation to be delivering services at a patient level, the better. And that's something that obviously needs a lot of people to come together with. So digital itself is not necessarily the problem there, but actually it's about how do we commission that and how do we deliver that. And then you've got a problem as when you do establish good technology, it's maintaining the funding for that technology. And we are aware of some situations where where funding is being withdrawn, and therefore good services may not be allowed to continue. So these are very real problems and very real issues that need sort of national solutions, really. But we do need to, and I'm sure there would be an appetite, but we do need to make sure that that funding is nationally available, so that we're not leaving some people behind. For the patient record side of it, NHS England's done a lot of work there, and it will be mandatory later on this year for all practices, GP practices, to make patient records available from a prospective perspective. That means anything that you from that date onwards you'll be able to access. You can request that your GP surgery open up your previous medical records for you to view online, and so those requests can be made with practices. And obviously having access to that information is really important. It's a huge issue then when you start to look at digital records via hospital because at the moment we do not have a technology solution that integrates all of that. But we have seen some real progress. I mean, I can say locally that our hospital community teams have access to our records, our computer systems, and vice versa. So those barriers are starting to fall and they are starting to come down. It's not perfect, but there are moves in the right direction, I think.
I'm just going to also look at, Faris, while we're on that subject of records. Joseph says, patients have a legal right to their medical records free of charge and in an accessible form from their surgery. However, some primary care, it always does this when I'm in the middle of a question, it jumps. However, some primary care practices are still providing medical records via CD, something a great many patients do not. Oh gosh, I didn't know there was still CDs out there for that kind of thing. Something that patients do not have the capability to use, probably a more commonplace inequality in this age than the experience of patients without computers. How can such surgeries be made to update their processes to adopt basic practices such as sending records via email, given that their current processes arguably breach GDPR? I'm not suggesting your surgery does this, Faris, but that does sound like it is a problem for some people in Britain.
Yes, and it might well be. I mean, certainly if an individual wants to access their patient records, and that is, and that is a very positive thing, because we need to empower patients to take control of their own health. And it means that if you see a doctor, you'll be able to review the notes, you'll be able to see exactly what the plan was, you're all on the same wavelength. So it's a very sensible thing to have access to. You should be able to contact your practice to open up online access to the medical record, and the GP surgery will have their own process that you may need to follow in order to do that. The GP surgery would need to then open up that access and give permission. If they're not willing to do that, then you can still you can still do subject access requests and other things to get a paper form of your notes. So that is still possible. Online is best if you can, because it's something that you can navigate in your own time. But practices should be able to do that. I think if you had any concern with being able to do that, obviously speak to the practice manager of that surgery, or the local ICB.
Hopefully they can help. Susie, just going back to mental health inequalities, what common mistakes have you seen in trying to address those inequalities in that particular area?
I think probably the biggest mistake is not including, I can only speak about young people, but not including young people when you're trying to design and build a service or a product for them. It's absurd not to include them from the very beginning. When we started out, we built a very rudimentary MVP, and we worked with young people in year 10s. They were about 16 years old in 3 different schools around the country. And we literally watched them take it apart, hack it. And from that process, we learned exactly what they needed, what they didn't want. And then we went away and we built an app that met their needs. And building an app is an iterative process. You have to constantly listen to your users. And we have learned by listening to them and what they need, how to build and develop. And in that way, we have learned that, for example, we were supporting really high numbers of young people who are autistic. We've just done a huge research project where 1,800 autistic young people took part, and we have learned so much, and we're now going to build another development part to specifically support their needs. And it's all about working with them to learn. It's also about understanding that when young people have a specific condition, they do not want to be defined by that. And we learned that very early on as well. So we went to the Midlands, and we went to talk to sort of teenage mums. They were about 14, and they all had children, and they were being educated in a special school where it was all geared around the fact that they were mothers. And when we spoke to them, all their education, everything was about the fact that they were young mums. They didn't want to be defined by that at all. They wanted to talk about their body image, or the fact that they broke up with their boyfriend, or the fact that they were going to fail their exams. They wanted a holistic support solution that wasn't mediated through their specific situation. And it's the same, I've seen people try to set up peer support groups for people with diabetes, and it's all about the condition. And actually for young people that, we are a mental health service under the mental health umbrella. Young people can talk about anything. They can get support if they need contraception, if they want to talk about bereavement, if they want to talk about family conflict or their parents getting divorced. It all comes under a mental health umbrella, but it's flexible to allow them to talk about all the different aspects of their life. So I think that's the main thing, is just to listen to the audience and work with them to develop something that meets their needs.
Susie, Helen, you're nodding away there. It just struck me actually while Susie was talking that, of course, you know, having two children myself, 19 and 14 years old, you know, our children are digital natives as well. So as well as people perhaps not, you know, wanting to be a bit more anonymous with mental health and things like that, they are used to communicating everything via, you know, whether it's ordering their Uber Eats or whatever, it's all on the phone. And you know, my little boy, if he has a drink from Starbucks, he's ordered it before we go in because he's done it on his phone and doesn't queue. And so I suppose digital is going to feel a lot more natural to them. But I'm just wondering, Helen, whether some of what Susie said there, particularly talking about mental health and autism, whether some of that resonated with you and whether you've got any examples of what you're doing, you know, in Yorkshire along those lines.
Yes, very much so. And I think, you know, it speaks to the conversations that we have, with, as I mentioned, with, you know, innovators and adopters all the time, really, in terms of thinking about your technology, your product, what's the end user going to look like? What's the end user experience? Have you co-designed and developed your technology with prospective end users? Have you tested your technology on data that's representative of the end users? So there's no sort of inherent bias associated with the outputs, maybe of your AI algorithm, etc. So there's a really broad perspective that one has to take. I think just in response to that latter point, as an example, so at the moment there's a competition which is called SBRI, so that's the Small Business Research Initiative, which is led by NHS England. And at the moment there's a live call around technologies to support learning disabilities and autism, of which I'm a panel participant. And there's some amazing technologies that are coming through there, co-developed and co-led by charities and people with lived experience and technologists, all aiming to improve the outcomes and experience and treatment and access of people who might be living with autism. So it's a fascinating thing, and I think it's so important, as I think we've all acknowledged, that people whose lives will be touched by this are involved in the design, the measurement, the evaluation, and the longitudinal impact of any technology, really, and how it feels for the end user.
Yeah, it's really important, isn't it, that end user is really thought about in all of this. Susie, were you about to say something there?
I was going to say, Helen, we were phase one of that SBRI competition. That was our 1,800 young people were part of that.
Was it? Was
so
it?
We're going for phase two now.
Oh, fantastic. It sounds like you're doing some amazing work there, Susie. Faris, with good things, there always comes challenges, barriers. What barriers are you seeing to the work that certainly you're trying to do in Warwickshire?
Yeah, I think the barriers locally were the same as they are anywhere, and the barrier to digital is access to the infrastructure, isn't it? It's to have the smart device, it's to have the internet connection. So there will always be those barriers, but those barriers are diminishing over time. People's accessibility is getting greater. Digital literacy, but we've actually seen a real shift in that since COVID and lockdowns. People are using online technologies much more, so our digital literacy rates are rising. But again, it is a potential barrier. We've touched upon commissioning, so it's making sure that there is funds available for anybody in the country, in any patch of the country, to have access. So the funding is a barrier, but something that is obviously not insurmountable. And then it's the product, I think, and it's getting the right products out there. And I think really what Susie said and the work she's done is absolutely spot on. We need to make sure, and innovators need to make sure, that the products that they are developing are meeting a definite need, and that those products are co-developed with those end users and perhaps with clinicians as well, to get a better feel for where that fits into the patient's journey, and where that sort of interlinks with current processes and current treatments and interventions. So I think obviously the great thing with technology is there's sort of no end to it, is there? So the barrier are the own limitations of our imagination, I think. But it's just making sure that the technology that is coming online and does continue is appropriately funded and co-developed with those who can help develop those products further.
Absolutely. And Helen, how can AHSNs like yours support SMEs with digital innovation? Because that's an important area too, isn't it?
Yes, so all HSNs, such as mine, have a commercial support team. So we're available to meet with SMEs who may be designing or wanting to bring a digital product to the NHS. We can do bespoke one-on-one support. We do innovation surgeries where we'll bring together experts and get clinical advice and clinical input. And very crucially, where we know that it will meet a prospective unmet need within our geography, we can broker introductions with potential adopters. We can talk about the design. We can talk about the level of evidence required within different populations, because I think, as we've acknowledged this morning, there is variation across the country. There's different needs, different populations, different commissioning rules. So we can help to sort of navigate all of that. And to think about, obviously, there's other things as well about the regulatory environment, the accessibility. We've talked about the end user experience. So there's a whole breadth of things really that we can help advice and guidance around for an innovator who may have a really exciting digital solution which they feel could really help with the inequalities agenda.
And is it easy to find you, Helen? Is it a case of Googling and putting a message on your website if people want to get in touch? I'm just thinking if anybody's listening in the audience and thinks they'd like to get in touch.
Yeah, you can just Google us, and there's a section on the website that says for innovators, and you can send an sort of an inquiry form in, and we'll come back to you. And then, depending upon what advice it is, we can link you up with the right people, have a session with you, talk through some of the maybe the policy levers, some of the competitions or grant funding that may be available. There's a whole plethora of different sort of conversations that we could be having.
I've just spotted a question from Delphine Fattori, who was a panelist on our first panel this morning. Susie, I'll start with you and see if you've got any thoughts on this. Delphine says, how can digital tools meet many needs, in particular for people with learning difficulties, as digital can be seen as a barrier by itself for some as well as an opportunity for others? Not all patients are the same. I'm just putting that question to you, given the fact you've been dealing in autism and mental health, and I'm just wondering if people with learning difficulties has perhaps come across, something that you've considered doing and
Absolutely. So the reason we did the autism study was because we discovered, we did a survey, and there was 1,200 responses, and 17% of them told us that they were autistic. So we worked with the in-app data that had been generated by about 700 young people, and we discovered that they were using the app 7 times more than neurotypical users. That 32% of them had made a high-risk post. So I'm not sure if you're aware, but the level of mental illness in young people who are autistic is so much higher, and they are much more likely to be suicidal. But we unpacked that, and we did a big mixed method survey. We had over 850 young people, and we discovered an awful lot about the barriers and the challenges. And so many of those young people have learning difficulties. A lot of them are nonverbal. I did one-to-one interviews via email, text chat, and video, camera on, camera off, with young people. And what we found was that the text-based system really works for them, because nobody's judging their spelling. Nobody's worried about whether they use capital letters or full stops. It's a slow process because it's moderated, and that asynchronous communication works really well. There's no pressure for immediacy. They don't have to respond immediately, and they don't have to reply immediately. We also have, we don't have likes or anything competitive, but we do have empathy and gratitude buttons, and they animate and say what they mean. So they say, I feel the same, that really helped me. Things like that, where there's like ways to interact, but they don't have to work out what to say. So they're engaging, but at their own pace and when they feel comfortable. So actually, we have inadvertently, without actually organising it, created a system which is very good for young people with learning difficulties. It's very easy for them to enter at whatever level, and it's non-judgmental and anonymous and safe. So that's something we want to develop in phase 2 of our SBRI, but it is actually a great platform for young people with any level of capability in terms of texting.
Fantastic, and thanks to Delphine putting that question in. Faris, Samar says there's some literature on bias in AI and how this can exacerbate health inequalities. What are your approaches to ensuring that the application of AI in healthcare is based on biased data and that it doesn't entrench inequalities?
Big question, and obviously AI is an emerging technology in the sphere of healthcare at the moment, and I sense we don't have that much data at the moment, and we don't have that much in terms of marketable product and at the moment, or we're not seeing it. AI is not being utilised particularly heavily within sort of the NHS health sphere at the moment. So I don't know about the data, and I'm not aware that there's too much out there right now. Obviously, as we've touched upon, technologies, there is the chance that it could exacerbate health inequalities, and that's something we just have to be mindful of, but not afraid of necessarily. We shouldn't let that hold us back from developing and innovating, because actually, as we move to a period where we've got more of an understanding of perhaps personalized care, making sure that we have menus of options, different ways of accessing care and different forms of delivering care, we actually create a more broad offer to our patients. So there is always the risk it can do that, but I think technology just needs to deliver more options and give people more options and more access, which means we can reach out to more people. And hopefully, if we do that cautiously and sensibly, we can reduce that risk of exacerbating a health inequality.
Helen, that is the case, really, isn't it?
Yes, absolutely. I think, looking through the lens of inequality in terms of study design, in terms of evaluation and real world evaluation, having a diverse, group or sort of steering group or oversight group with experts in the field, if you are introducing something like an AI, to make sure there isn't any sort of bias, or to do that testing and the prototyping. So to have, that diversity of leadership, clinical input, and really importantly, as we kept saying, the end user in mind, and the people who will be using the product at the end, or who may be experiencing the product at the end, to make sure that their voices are heard right throughout the adoption journey.
I really appreciate all of you speaking today. We've had another fantastic conversation. Thank you very much to Susie, to Faris and Helen for giving some valuable insight. And to those of you in our audience who have submitted questions, if I haven't got to your question this time, don't let it put you off on our next panels throughout the day, because I will get to as many as I can. And it was also fantastic to have Tell Me partnering this panel, and some great work being done there by Susie. So time now to take another break. Please take this opportunity to network with your fellow delegates by using our speed networking function, and I'll see you at 11:35 for our final session before lunch. Well done.